hopefully some of it are meeting. These are my disclosures. The circle ones are relevant. So what am I going to talk about? First, comparing the different anti-VEGF agents in terms of their structure, pharmacodynamics, efficacy, durability, side effects. Second, looking at different treatment paradigms, monthly, PRN, treat and extend. Third, talking about pigment epithelial detachment, does it matter or not? Third, very briefly, mentioning some aspects of polychoroidal vasculopathy, which Dr. Koh is going to talk about in detail, and retinal angiomatous proliferation. And then finally, some future treatments. So, comparing the VEGF agents. Well, this shows you the structure of the different agents. Bevacizumab, full-length antibody, ranibizumab, FAB fragment. They both bind to all the isoforms of VEGF-A. VEGF trap, also known as aflibercept, actually consists of domain 2 from VEGF receptor 1, domain 3 from VEGF receptor 2, and an FC component. And this has different pharmacology. It binds to VEGF-A isoforms, like the other two, but it also binds to VEGF-B, and it binds to placental growth factor. Something which is propagated in literature, which in my reading literature is completely false, is that aflibercept has a higher affinity for VEGF-A than ranibizumab. It's absolutely not the case. I'm happy to discuss it afterwards and show you the papers that illustrate that. But it's not only my opinion. If you look at the clinical studies I'm going to show you, they are most consistent with the idea that there's no difference in the affinity. These three drugs, in my opinion, have very, very similar efficacy, and they also demonstrate a ceiling effect of benefit. So if we look at the View trials for aflibercept, for the 2Q8 regimen, 2 milligrams every 8 weeks after the 3 monthly loading doses, you get about an 8-letter improvement. If you look at the Harbor trial, with the 0.5 milligrams every month, you get an 11-letter, 0.5 milligrams PRN, so that's 3 loading doses, followed by additional treatments needed. You get about 8 letters. And in the CAT trial, with bevacizumab and ranibizumab were compared, with the monthly treatments, you get about 8 letters, about 6 letters with the PRN treatment. So they all are about the same in terms of efficacy, and they all demonstrate a ceiling effect, which means there's room for new treatments. In terms of the frequency of injections, if we look at the CAT trial, and I'm just going to focus on the PRN data because I don't think most people treat monthly. There statistically was a slightly lower frequency of injections with ranibizumab, but this is, in my opinion, not a clinically important difference. If we look at the View trials, where 0.5 milligram ranibizumab was compared to 2 milligram aflibercept, in the first year of the treatment, the injection frequency was protocol-driven, so it's irrelevant. But in the second year of the injection, patients were seen every month, and they were given injections if they needed it. But if they hadn't received an injection in 12 weeks, they had to receive an injection. So that's the CAT PRN quarterly protocol. And if you look there, there were an average during year 2 of 4.7 injections with ranibizumab and 4.2 with aflibercept. Now, post hoc analysis says this difference is statistically significant, but I don't think you need to be a statistician to know that is not a clinically important difference. You might say, well, the CAT PRN 12-week injection interval, how do you compare that with real life? Well, it turns out in real life, there's virtually nobody that can go longer than 12 weeks without getting an injection. So this really is a very good estimate of the durability of the treatments. And in fact, if you look at the OCT data for the View trials, remember, the way it works is that initially you get an injection in month 1, month 2, month 3, and then if you're in the 2Q8 arm, you don't get an injection until 8 weeks later. And what you can see is that just before those 8-week injections, the OCTs are getting thicker. And that's because the drug doesn't really last 8 weeks. It probably lasts closer to 6 weeks. So I'd say very similar durability, if not identical. What about geographic atrophy? This is an example of a case of geographic atrophy in the CAT trial. You can see the choroidal vessel at the beginning of the study, and by week 104, you've got several areas of atrophy, including one where the new vessel is located. But now you know all about why that area of atrophy appeared. Well, what's interesting, if you look, just focusing for the moment on ranibizumab, first thing you realize is that most of the atrophy that developed in the CAT trial was extrafoveal. And that explains why, even though atrophy developed, the from a statistical point of view, was not an important cause of visual loss. The next thing to notice is that the people who had the highest rate of atrophy were the ones who were on the monthly treatment versus the PRN treatment, 21 versus 11%. Well, is there any way to predict who's going to get atrophy? Well, the baseline predictors were having bad vision, having a RAP lesion, you know why that is now, having geographic atrophy in the fellow eye, that's called concordance, intraretinal fluid, why is that? Because RAP lesions are usually associated with intraretinal rather than subretinal fluid. Baseline factors associated with lower risk were block fluorescence, some subretinal fluid despite windbreaking treatment, and subretinal tissue complex that was somewhat thick. So that probably means a type 1 vision. And DNA. The main finding from CAPA was that monthly dosing, either with ranibizumab or bevacizumab, gave you a higher risk of developing atrophy. And if you want to be quantitative, if you had monthly injections, there was a 12.4% incidence of GA in year 2, and those patients received about 23 injections. If you had PRN injections, then the incidence was 8.8% in year 2, and those patients had about 13 injections. And if you switched from monthly to PRN in year 2, you had an intermediate level of risk with an intermediate number of injections. They looked for genetic associations and were not able to identify. Now, Ivan noticed the same phenomenon, the Ivan study. And it's interesting that when it comes to looking at the effect of the individual agent, Ivan and Kat had different results. Kat suggested that you had a lesser risk of atrophy with bevacizumab. Ivan suggested that you had a lesser risk of atrophy with ranibizumab, although both of these confidence intervals overlap once, so it wasn't statistically significant. But what they both agreed on is that if you had PRN treatment, you had a lower risk of atrophy. So that's real. Well, the Harbor study also addressed the risk of developing atrophy. It's a study where patients were randomly assigned to getting 0.5 milligrams ranibizumab monthly or PRN after 3 loading doses, or 2 milligrams ranibizumab monthly or PRN after 3 loading doses. And then one of the things they looked at was the development of atrophy. And among study eyes that had no atrophy at baseline, you can see that by month 24, the prevalence of the atrophy was the same as was observed in Ivan and Kat. So I think this is a real finding. But we have a little bit more data here from Harvard. What we find is that although there is a consistently slightly worse visual outcome when atrophy is present, it's not clinically important or visually or clinic or statistically significant. And even if you do have atrophy, there's clearly a benefit to getting the treatment. So atrophy is not a contraindication to getting anti-VEGF therapy, especially if you compare it to untreated wet AMD in the retina. So that's one of the side effects, which is an ocular side effect. Then there are the class of side effects called systemic side effects. To that, we need to go back a little bit and talk about what's known about what happens to patients when you do VEGF signaling blockade, by any means, either by blocking VEGF or by blocking the tyrosine kinases that are activated by VEGF. And what you can see is that VEGF signaling blockade leads to decreased nitrous oxide production and prostaglandin I2 production, which in turn leads to vasoconstriction and leads to a tendency to hypertension, which is one of the well-known systemic complications of Avastin use when you're using it to treat cancer. Another thing that happens is vascular endothelial cell death, because VEGF is trophic for vascular endothelial cells. And when the endothelial cells die, you expose the underlying extracellular matrix, which contains procoagulant phospholipids. And that leads to a tendency to thrombosis, which explains the other well-known side effect of systemic anti-VEGF blockade, which is CVA and thrombosis systemic. Well, quick intravitreal injection of these agents lead to systemic side effects. I mean, these are much, much lower doses than what patients receive for cancer. The answer to that question is yes, it does. And the way this was studied was by looking at a very high-risk group of patients, patients who have diabetic retinopathy and diabetic macular edema. It's known that patients with diabetes have a much higher risk of stroke than the average, and patients with diabetic macular edema have a higher risk of cardiovascular complications than diabetic patients who do not have macular edema. So Dr. Avery and Gordon looked at the subgroup of patients in the RIDE and RISE trials, which studied ranibizumab, and in the VIVID and VISTA trials, which studied aflibercept, focusing on the patients that have the highest exposure to the drug. So these would be the patients that received monthly injections of 0.5 milligram ranibizumab in RIDE and RISE, or monthly injections of 2 milligrams of aflibercept in VIVID and VISTA. What did they find? The risk of all-cause mortality was increased by a factor of 3 with ranibizumab and with aflibercept. And when you pool the patient data for the meta-analysis, that risk persists and it's very highly significant. So what this shows is that data from randomized controlled clinical trials in patients with diabetic macular edema proved that intravitreal ranibizumab and aflibercept is associated with a higher risk of systemic complications among the patients that have highest exposure. Well, okay. Is there any reason we should be concerned about that in patients with age-related macular degeneration? Well, let me make the case for the biologic plausibility of that concern. The first has to do with pharmacokinetics. If you look at the blood concentrations of aflibercept, bevacizumab, and ranibizumab after intravitreal injection, you'll see that 90 days after your third dose, excuse me, a month after your third dose, the blood level of aflibercept and bevacizumab is at the IC50, which means the concentration of the drug in your blood is able to inhibit 50% of the biological effect of VEGF. That's a clinically and pharmacologically significant concentration of drug in your blood. In contrast, ranibizumab is a fraction of the biologically significant level. Furthermore, if we actually look at the plasma VEGF levels in these patients, and this was done by Bob Avery in patients with age-related macular degeneration, you can see that patients who receive intravitreal aflibercept or bevacizumab have profoundly lower systemic VEGF levels, whereas patients receiving ranibizumab do not. And this was not a one-off event. This was reproduced in a different study by Wang, where we look at a single intravitreal 2 milligram injection of aflibercept, and you can see that there's a profound reduction of plasma VEGF levels for up to 2 months. In contrast, if we look at a single intravitreal 0.5 milligram ranibizumab injection, there is no significant reduction in plasma VEGF levels, even at 1 week. If that's the case, why is it that it has not been demonstrated in AMD trials consistently that there's an increased risk of systemic side effects with intravitreal injection of these drugs? Well, I think the answer is limitations in study design. First of all, the registration trials are not powered to look at rare side effects. They're powered to assess efficacy. Low-frequency adverse events are not going to be detectable in these trials. And that's also true for meta-analyses of these trials, depending on the event rates and the magnitude of the treatment effect. For example, when we looked at a bunch of the ranibizumab trials in patients with age-related macular degeneration, we did a power calculation. If you assume appropriately that the stroke rate in the control group is 1%, even with all the patients we enrolled in this study, we only had a 16% power to detect a doubling in the risk of stroke, and a 52% power to detect a tripling in the risk. So you'd have to see an enormously increased risk for any of these trials to demonstrate the increased systemic risk. The other problem with these trials is a bias of ascertainment. For example, in View 1 and View 2, if a person developed a stroke during treatment, it wasn't attributed to the treatment if the stroke occurred more than 30 days after the injection. And as you know, the drug lasts for much longer than that. And in the ranibizumab trials, patients were excluded if they were at high risk of stroke in many of these trials. So that creates another bias of ascertainment. So I think there is a risk of systemic side effects. Unfortunately, we can't figure out who that person is that's at risk. Okay, now posology. What's the best treatment paradigm? Of course, I don't know the answer to that, but I'm going to propose it. First, let's look at how often people need to be injected with 0.5 milligram ranibizumab. It turns out that in the Harbor study, among the patients who are enrolled in the PRM, that is a monthly injection times 3, and then followed every month with additional injections as needed, almost half the patients needed injections every 2 months instead of every month. There's a small subset of patients that require injections every month, only 7%. So it's almost certainly the case that if we inject patients every single month, we are over-treating. And that creates a concern about the development of atrophy, not to mention the inconvenience of the patient, the cost of the drug. And these sorts of issues have led to treat and extend, which is a dosing regimen where we start by doing monthly injections until we see a maximal clinical response. And then we increase the intervals between the visits and the injections until we get to the maximum tolerated interval. So if I could summarize this for you in one sentence, this is what I would say. When you're treating with PRN, what you know is going to happen is you're going to see the patient every month. What you don't know is going to happen is whether you're going to inject them every month. When you're treating with treat and extend, what you know is going to happen is every time you see the patient, you're going to inject them. What you don't know is when you're going to see them next. That's what you decide as part of the treat and extend therapy. I'm going to try to explain that in more detail. Well, why should we go through all of this effort? Well, if you look at the Medicare database, it turns out that in real life, we're injecting the patients much less frequently than was done in the pivotal trials. And that's bad for the visual outcome. Not only that, if we use treat and extend, we can probably reduce the cost almost by half because we reduce the number of injections, 16,000 versus 28,000. And of course, we reduce the burden to the patient, the crowding of the clinics. This isn't just true in the United States. The AURA study looked at a number of different countries, many patients, 2,200 patients roughly. And they found pretty good results for the first 3 months, and then the vision results were just terrible. I'll show you what they were in a second. And probably they're terrible because patients received very few injections. Instead of getting, say, 11 a year, they got 5 in the first year. Instead of getting 11 in the second year, they got 2 in the second. And people who got more injections had better vision. Let me show you what I mean. The best performers were in the United Kingdom. They got 9 injections over 2 years. I can tell you that in treat and extend, they would have gotten around 16 injections. They only got 9. Therefore, they only had 4 letters of improvement, whereas they should have had about 8. The worst performer was Italy, where they only got about 5 injections over 2 years, and they actually lost 3 letters during the 2 years of follow-up. So, there's a lot of data, and most of it's not controlled data on the value of treat and extend, but what the data indicate is that you get better visual and anatomic outcomes, and this is really reliable. During the first year, the patients get around 8 injections. During the second year, they get somewhere between 6 and 7. You'll see that when I show you the studies in a little bit. As a result, the patients have fewer visits. When they come for the visit, they know what to expect, they know they're going to get an injection. I think that that's good for them psychologically, and it also makes it easier to coordinate the office. And there may be a lower risk of morbidity, although I think that's a less important reason in practice. How do you do it? You give monthly injections until you get the maximal response. What does that mean? That means there's no intraretinal or subretinal fluid and hemorrhage, or that there's no further reduction in the subretinal fluid or the intraretinal fluid after receiving 2 consecutive visit injections and no new intraretinal hemorrhage. Some physicians go even a step further and insist that you have flattening the PED. I think that's completely unnecessary and maybe a bad idea. And some physicians insist that you keep injecting until you get no further improvement in the visual acuity. I don't do it that way, but I can understand why you would. Let me show you why I think it's not necessary to be aggressive about picking up filial detachments. This is a patient of mine who's 80 years old. It was seen in 2004. They had brachytherapy in the right eye, bad vision. In the left eye, you can't see it very clearly, but there's a picking up filial detachment with vision in 2040. Then 4 years later, now we're looking at the fluorescein. This is their bad eye. This is the eye with pigment epithelial detachment. No treatment, we're still 2040. And then eventually, 8 years later, this is the OCT. the right eye, the left eye is still a 20/40 with this pigmented radial detachment, which is not a serious feature. But eventually, the patient does develop some subretinal fluid in the left eye, and that's when he gets the injections. And then, following up a couple months later, the fluid is gone, the vision is at 20/60, and a few years later, he's still 20/60. And I can tell you, I just saw him a couple weeks ago, he's still 20/60. So there was nothing lost by being conservative about treating the pigmented fluid detachment. How do you know when to extend the treatment? So you've injected them, you've decided they're stable, you've been seeing them, say, every 4 weeks, now they're stable. What do you do next? What you want to do next is see them stay in 6 weeks. When is it ready to make that transition from 4 to 6 weeks? There's no fluid, there's no persistent hemorrhage. I don't think it matters if the pigmented fluid detachment is flat or not. Once you get the maximum response, you continue to extend the follow-up interval. So, for example, if I see them back in 6 weeks and there's no disease activity, I inject them, I might see them back in 8 weeks. If I see them in 8 weeks, there's no disease activity, I inject them, and I might see them back in 10 weeks, all the way out to 12 weeks. Most people don't extend the follow-up interval to more than 12 weeks. What if the OCT looks the same and the fundus exam looks the same, but their vision's a little worse, maybe a line worse? Does that affect the decision to extend the treatment? That's a clinical judgment call. In general, a small change in vision would not make you change the injection movement, but you have to use your vision. If they are persistent, despite these monthly injections, one of the things you ought to think about is whether you have the right diagnosis. And that could prompt you to repeat all your diagnostic studies to reconsider the situation. As I mentioned to you, once they're stable, you keep injecting the intervals of injection and visits by 2 weeks until you get to 12. When would I not do that? It would be if the person was at particularly high risk, so maybe a person who's got a large lesion or is using anticoagulants, or maybe a monocular patient, maybe I would not go beyond 8 weeks for the follow-up intervals. But that's just me. If you see a minor change, so now you see them back, they've been doing fine at 8 weeks intervals, let's say, and they come back, and of course you're going to inject them because that's what you do with treat and extend. You always inject them when they come back. But they actually have some disease activity. So now what should you do? Well, that depends on how much disease activity they have. If there's a minor change, so a little bit of subretinal fluid, minor visual loss, you probably would bring them back in 6 weeks. Before it was 8 weeks, now you're going to reduce it to 6 weeks. But what if they have a major change, like bleeding under the fovea, or a big bleed, or a significant loss of vision? Then what would I do? I'd bring them back in 4 weeks. That visit, I would repeat the diagnostic studies to be sure I have the right diagnosis. And I keep them at that 4-week interval until they show stabilization from 2 to 3 consecutive visits. And if they did, then I would begin to extend the visits again. So the criteria for retreatment, as I mentioned to you, would be fluid, persistent or new hemorrhage, possibly leakage on the fluorescein, although usually I don't get fluorescein, or loss of vision. Things you can do to modify the treatment, aside from changing the interval and follow-up, change the dose. I mentioned this in the third lecture. Consider combination therapy, say with DVT. Change the medication. I'll talk about that in the third lecture. Or, if they're doing well, consider a treatment suspension. So suppose you've been following a patient for a year, and you've been seeing them every 3 months, and you inject them, but there's no disease activity. What should you do then? What you could do is say, sir, I'm not going to inject you today. I'm not going to do it. But instead of seeing you in 12 weeks, I'm going to see you in 8 weeks. And if you see them in 8 weeks, and they have disease activity, of course, you'll inject them and start again. But if they have no disease activity in 8 weeks, then you might just see them again in 8 weeks. And once you get that pattern established, you might go out to 12 weeks with no injection. So we call it a drug holiday. The treatment center of fluid recurrences, better long-term visual outcome because there's better administration of drug, fewer patient visits, which is great for the doctor and the patient. There's the guarantee of injections. There's a lower cost of treatment, which is very good for the patient and the healthcare system, if not for the doctor, and more predictable workload, which is very important for the doctor and the patient. The disadvantages is the treat extend, you're going to over-treat. I'll show you that. And you aren't going to identify the people who really don't need many injections at all. And there may be a greater risk of atrophy if you're giving more injections than the patient needs. Let me illustrate to you a person who would be very hard to detect with treat extend. And this is the highly responsive patient. This is a patient of mine who's an executive. He presented with 20/40 vision with a coronary vessel, which you can see here on the angiogram. He got an injection, and his other eyes is fine. He did very well with that one injection. So we did one or three, I don't know for sure. His other eye is fine. Here's his fluid when he presented with his problem 20/40 vision. He got the 3 injections as usual, and he came back. So this is 2008. He came back and he was fine. And because I was doing PRM, I didn't give him any injections. Whole year passed, no injections at all. He came back while I was out of town. This is when I was out of town. He was complaining of a visual abnormality. My colleague, Dr. Pagat, saw him, got the OCT. I think you'll agree there's nothing in the OCT. So she didn't inject him. I was back in town. You see, this is October. He came back a month later because he was convinced there was something wrong. And there was something wrong. He has reactivation of disease. He got an injection. He did well. 2010, now it's 2016. That's the last time I ever injected him. So if I did treat and extend, he would be way over-treated. So this is an advantage of PRM. This is 2015, but I saw him now because it's just like this. When would you consider PRM rather than treat and extend? Well, I think if the fellow eye has significant geographic atrophy, if the person has a RAP lesion because of the risk of geographic atrophy, if they have reticular pseudodrusen because of the risk of geographic atrophy, and if they have a very thin choroid because of the risk of geographic atrophy. You know, all those things now because of the pathology measure. So here's a patient that illustrates that. Here he is 2150 and 2040. Now this 2040 eye, which has atrophy, he thinks this is his worst eye. He thinks this is his better eye. And in fact, once you treat this eye, he doesn't get normal thickness, but he comes back to 20/40. So this is a person who, because he's clearly at risk of losing his fovea in his right eye, he prefers to be treated with PRM rather than treat and extend. In fact, he ends up being treated somewhere between every 6 and 8 weeks. When do you go from PRM to treat and extend? Well, it's very simple. You use the same criteria for switching to treat and extend as you would for when you would extend a treatment. That's to say, when the macula is dry, the disease is stable, that's a good time to switch from PRM to treatment extend. Why would I defer treatment extend? Patient choice, obviously. If the person, or if I think they're better off with a minimum number of injections, if they have a history of severe glaucoma, or perhaps if they have a history of endophthalmitis. Another possible time, and I'm not so sure about that, is patients that need bilateral injections. So here's a person who's got bilateral disease. He's 20/30 in his good eye, 20/80 in the bad eye. The good eye actually has subretinal fluid, but the bad eye doesn't. So I probably wouldn't inject with that eye again, and I didn't. And then I see him back in a couple of weeks, and now the eye on the left does have fluid, so I inject it. And so that's a situation where you have to decide how you want to handle the issue of bilateral injections. We've undergone this evolution. We started out doing monthly treatment with Anchor and Marine. Then we went to PRM treatment based on the Pronto study, followed by the Harvard study. And now we are in this new era of the treatment extend. I want to show you a couple of studies that illustrate the principles that I've tried to describe in broad categories for the past 30 minutes. The only randomized study I can show you is the Lucas trial, which looked at a treatment extend paradigm comparing ranibizumab and bevacizumab. I'm just going to show you the ranibizumab data. So the way it worked is you'd inject the patient every 4 weeks, and then if they had no more disease activity, you'd extend the interval to 6 weeks, no disease activity, inject and extend the interval to 8 weeks, no disease activity, inject and extend it to 10, and all the way up to 12. But if they show disease activity, you'd inject and bring them back in 4 weeks. So that's the typical treatment extend paradigm. And what you can see with that paradigm for the ranibizumab cohort was that the number of injections during the first year was 8. Remember I told you 8 or 9 in the first year. The number in the second year was 6.9. Remember I said between 6 and 7 in the second year. And the amount of visual improvement was very good, 8 letters and 6.6 letters in the second year. And what's really useful is the number of visits. Almost half the patients didn't need to be seen any more frequently between 10 and 12 weeks. That's a great reduction in burden of treatment to the doctor and to the patient, and a tremendous cost savings to the healthcare system and to the patient. Here's a different study by Folster, where they did treat and extend. The mean number of injections in the first year, once again, is 8. And the intervals that were used ended up being on average around 9 weeks. And you can see that the visual improvement, this is logmar, was very good, around 70 letters, close to 70 letters, which is common. There was rapid reduction in the OCT thickness that was persistent. This is a different study by Betty. During 1 year, the number of injections and visits was around 9. During the second year, it was around 6. And you can see excellent visual improvement of 9.5 and 8 letters in years 1 and year 2. So this is all very good. And then Abraham, which was comparing treatment extent to PRN, fairly large study of 90 patients, but it's retrospective. And what I want to show you is that the visual gains were actually better for the treatment extend than for the PRN group, 10.8 versus 2 letters. And the reason is that the number of injections was greater for the treatment extend than for the PRN group, 7.8 versus 5.2. And this is the recurrent theme, that in fact, when you do PRN treatment, you actually, for whatever reason, end up giving fewer injections to the patient than you would if you did the treatment extend program. So that summarizes what I want to say about treatment extend. Now I want to talk very briefly about pigment epithelial detachments. The Harbor study also provides some information, at least as it relates to ranibizumab, about PEDs. About half the patients had PEDs, and they ranged in size. Here's an example of the lowest quartile, the second quartile, the third quartile, and the quartile with the biggest PEDs. And independent of the quartile, it turned out that the ranibizumab could eliminate the PEDs in about half the patients with 0.5 milligrams, whether you were doing monthly or PRN treatment. And if you look at the visual improvement, it improved regardless of the PED status at baseline. So if we look at the 0.5 milligram monthly, you see the same amount of improvement if you have a baseline PED or acquired PED. And if you look at the PRN, again, similar visual outcomes. So what about the tough PEDs? The hard ones to resolve are the vascular PEDs. And of course, ranibizumab and aflibercept both can resolve those. This happens to be an example with ranibizumab. It's a 76-year-old patient, baseline vision of 20/80 with a PED height of 380 microns, getting monthly injections. By 3 months, the vision has improved a little. PED is collapsing. By 6 months, the vision is stable, but the PED continues to collapse. And by a year, the vision has improved overall by 2 months with a significant reduction in the height of the PED. I don't think that the collapse of the PED is why the patient's vision got better. I think the vision got better because of the elimination of subretinal fluid and retinal fluid. I think it's generally true that the serous PEDs respond most rapidly to any anti-VEGF therapy. Here's an example. A patient of mine who's being treated in his other eye, not the right eye, but the left eye. But in the right eye, he has vision of 20/30 in June. And then he comes back in September with decreased vision and a serous pigment epithelial detachment with a little bit of subretinal fluid right there. He gets injected, his PED flattens literally within a month, and his vision improves. And so that's really all I have to say about PEDs, except that I don't treat for the PED. I treat for the subretinal fluid and intraretinal fluid, the presence of hemorrhage or loss of vision. What about polyportal choroidal vasculopathy? So here we can see the polyps and the branching network. The OCT shows nicely this double layer sign there, which is really type 1 neovascularization, and the thumb-like polyp, which is pretty unique with this double dip. Well, it turns out the PCV responds very well to anti-VEGF therapy. Here we can see with ranibizumab, there's a nice reduction in foveal thickness over 24 months of treatment, and corresponding improvement in visual acuity. These are logmar numbers. And similar with aflibercept, you get a nice improvement in visual acuity. This is logmar, so when it goes down, the vision's getting better, and a reduction in foveal thickness. What about ranibizumab versus PDT? Dr. Coates probably meta-analysis that was done relatively recently. And the summary is that it looks as if you get better visual outcome with ranibizumab than you do with PDT. And in this particular study, there seemed to be a better thinning of the retina with ranibizumab than with PDT, although I'm not convinced of that. But where PDT clearly is better than PCV is that it induces the regression of the polyps, whereas that really does not happen with anti-VEGF therapy, not to any significant degree. What about combining ranibizumab with PDT for treatment of PCV? Again, Dr. Koh is going to give you a great deal of information about this, but very briefly, combining the two drugs gives you a regression of polyps because that's what PDT does, not ranibizumab. It doesn't give you better visual outcome. It does probably give you more thinning of the retina for the other vascular. What about retinal angiomatous proliferation? How does that respond to treatment? Well, just so you know, at least in the white population, it accounts for a not an insignificant fraction of neovascular AMD. And there are the stages that you may be familiar with: intraretinal stage 1, intra and subretinal stage 2, choroidal, that's subretinal, into the choroidal stage 3. And it's associated, as I mentioned, with reticular pseudodrusen, PED, and outer retinal cysts. Well, it turns out that RAP responds very well to anti-VEGF therapy, probably better than to PED. This was a study done by Dr. Silva, a fair number of patients with long follow-up, and they were able to stabilize the vision in about half the patients, with about a fifth preserving reading vision. There was a significant decrease in the central macular thickness in year 3, but not later on. Unfortunately, the thing that tended to limit the patient's vision was the evolution of geographic atrophy. And very relevant for what we're talking about now is that adding PDT in this, intermediate-sized series didn't improve visual outcome. So I wouldn't start off with combined therapy for RAP lesions. I would start with anti-VEGF therapy. And that's specifically because I'm concerned about precipitating more rapid progression to geographic atrophy. Now I want to fantasize with you about the future in the last 20 minutes of the lecture. I've showed you this slide before, where the different steps of angiogenesis are being attacked by different agents, all different steps, all different agents. And most of these have turned out to fail, except for these 3. But there are some that are in trial that might be interesting. What would be a good agent to add to anti-VEGF therapy for combination therapy? Well, in general, I think we want a pathway-specific agent because pathway-specific agents tend to have less toxicity. We'd want an agent that's synergistic because that leads to minimizing the dose of both agents with reduced toxicity, generally speaking. And we want something that induces abnormal vessel regression. Remember, angiogenesis is a normal biological activity that occurs all the time in our bodies. If angiogenesis were to stop completely, our gut would die and our brains would die. So we want to have angiogenesis therapy that's targeted to abnormal blood vessel production. So if these are the boundary conditions, we want to identify molecules that focus on the pathways involved in further vessel formation. We would like to attack 2 different steps in the progress of neovascularization, and we, of course, want to reduce the need for ongoing treatment, which is why we've been talking about treatment stem. Well, there are 3 drugs I want to mention: Fovista, squalene, and some drugs in progress that inhibit angiopoietin. So with Fovista, why are people interested in this? Because it was noticed in treating tumors that if you just block anti-VEGF with anti-VEGF therapy, if you treat early, when the tumor is young, you get good blockade of tumor growth. But if you treat later, when the tumor is more mature, the anti-VEGF therapy is not really effective. Whereas if you treat the tumor early with combined anti-VEGF and anti-PDGF therapy, you get good blockade of tumor growth, but you can even get good blockade if you treat when the tumor is more mature. And the reason for that is that as the blood vessels mature, they acquire pericytes, and pericytes provide VEGF and other factors to the new endothelium that makes them resistant to pharmacologically added VEGF blockade. Okay, so that is what led to the development of pegflunaramine, which we have called Fovista before. It is an anti-PDGF beta aptamer. It's a DNA aptamer. It binds to PDGF-beta with high affinity. And in animal models, this is what it does. Here's a picture of choroidal neovascularization. The corneal endothelial cells are red, and the corneal pericytes in the vessels are green. When you treat with a Provista, the green goes away, and that means the pericytes are gone. So now you're eliminating the endothelial cell source of VEGF, and you're making this susceptible to VEGF inhibition. Similarly, with retinal neovascularization, this is in an ROP model. When you treat with Provista, you eliminate the green pericytes and leave behind the red endothelial cells. Well, you probably have seen this slide before. This is from the phase 1 trial of Provista, where treatment with Provista and ranibizumab led to elimination of the choroidal neovascular in some patients and improving in visual acuity. And then a very large phase 2b study was done, where patients received different doses of Provista or sham injection combined with 0.5 milligram ranibizumab. And the results were very striking. And the patients who received 1.5 milligram Provista plus 0.5 milligram ranibizumab had a 10-letter gain versus a 6.5-letter gain in a ranibizumab monotherapy, which was a significant visual benefit. And as a result of that, there are 3 phase 3 trials underway right now. 2 looking at Provista with Lucentis versus Lucentis alone, and 1 looking at Provista combined either with Avastin or Eylea. The enrollment's complete, and we should have the top-line data sometime in December. The size of the phase 1 study is so large that I will be surprised if we don't see a difference between the combined therapy group and the ranibizumab monotherapy group. What I think we don't know is whether the magnitude of the difference will be reproduced in the phase 3 studies. If the magnitude of the difference is large, we'll have a new treatment of AMD. If the magnitude is small, then I'm not sure how that will be. The second drug I want to mention is squalene, which is an immunosteroid, and it's an angiostatic steroid. It's derived from the dog fish shark, and it blocks the sodium hydrogen ion exchanger. It also is a calmodulin chaperone, and the result is that it interferes with the mitogen-induced actin polymerization, which inhibits cell migration, so that will tend to reduce angiogenesis. And it also inhibits a number of different growth factors actions by blocking their second messenger signaling. So it could be a very useful molecule. And what's interesting is you can administer it as an eye drop. If you give the eye drop twice a day, you get measurable doses in the back of the eye. And a phase 2b study was done. And the idea was to combine ranibizumab with the eye drop, hoping that the frequency of ranibizumab injections would go down. And that was not the case. There was no difference between the combined therapy and the ranibizumab monotherapy group with regard to the frequency of the injections. But what was different was that the visual improvement in the combined therapy group was much better, both for patients with classic choroidal vessels and for occult choroidal vessels. So that's 11 letters of improvement in the combined therapy group versus 5 to 6 letters in the monotherapy group. So as a result, the phase 3 study is underway, where the eye drops will be combined with ranibizumab versus a placebo drop with ranibizumab. A large study, and we should have the results about a year from now. The last molecule I'll mention is an Ang2 inhibitor. In order to understand how it works, we need to know a little bit about the structure of the Tie receptor to which it binds. So the Tie receptor has 2 IgG-like domains, followed by 3 EGF-like domains, another IgG domain, 3 fibronectin domains, and 2 tyrosine kinase domains. So that's the structure of the Tie receptor to which the angiopoietins bind. The angiopoietins have a very monotonous structure. They have a superclustering domain because in order for the angiopoietins to work, they have to cluster. We'll see why in a second. A coiled domain, which allows the angiopoietins to bind together. And then a fibrinogen domain that binds to the second IgG portion of the Tie 2 receptor. So when you see this clustering of the angiopoietins, what that does is it clusters the tyrosine kinase domains of the Tie receptors, which leads to the biological effects of the angiopoietins. So there's angiopoietin 1, which stabilizes blood vessels. and angiopoietin-2, which helps to foster blood vessel growth. And that's why we're looking at inhibiting angiopoietin-2 as a way of blocking early vascularization. So Genentech Roche are looking at an angiopoietin inhibitor that's actually bifunctional. Part of the molecule binds Ang2, part binds VEGF-A. And Regeneron's looking at an angiopoietin inhibitor that's monofunctional. It's an IgG that just binds Ang2 with high affinity. These trials are in progress, but we ought to have the results in the spring of this year. I'll tell you a little bit more about the Genentech Roche molecule. This is the VEGF-A binding part and the Ang2 binding part. The phase 1 trial involved switching patients that were no longer responsive to monotherapy. And there were two cohorts, one that received ascending doses of the inhibitor, and one that received multiple doses and then launched to a higher dose. And there were no safety signals in this small study, and there was a suggestion of biological activity. The ascending dose cohort had 7 letters of improvement, as did the multiple dose cohort, with a corresponding reduction in the central retinal thickness. So there's going to be additional studies of this drug, both for DME and for AMD. Now, I want to mention the issue of timing, because if we do have combination therapy, timing is going to become very important. And I thought the best way to illustrate that is not with combination therapy, but with monotherapy using a drug that you all know exceedingly well. And it's the issue of penicillin to treat infections and how important timing is when you're using penicillin to treat infections. So you may not realize it, but the first trials of penicillin were done at Oxford. In a way, we could never do trials today, but there were some positive results. And so then they tried it in soldiers in North Africa during the Second World War. And the first trial, the way the hospitals are staged in a war zone is you have the primary, the secondary, and the tertiary hospitals. The tertiary is being as far away from the front as possible. And so those patients are the ones that have all the chronic infections. And when the penicillin was used in these patients, it was a total failure, completely a failure. And so Sir Harold Florey, who was the guy who figured out how to mass produce penicillin, said, stop. He said, quote, send me your cases early, I can't resurrect a corpse. So they went from the tertiary hospitals to the secondary hospitals, and they got somewhat better results, but it was still basically a failure. So here we are treating penicillin, treating infections with penicillin, and it's a failure. And that's because the timing is wrong. When they finally brought the penicillin to the advanced hospitals at the front line and were administering it at the time of primary wound closure, that's when they got the miraculous results, and that's when they recognized it to be successful. So now, we're going to think about combination therapy. Should combination therapy be administered simultaneously? Because that's what's going to happen for the Regeneron Roche drug that's bifunctional. Or should it not be? Should it be administered sequentially? And there's actually some data about this. Praveen Duggal compared patients that received Fovista and anti-VEGF therapy simultaneously to those who received Fovista before combined therapy and then received combined therapy. Small study, very small, but very different visual outcome. So this is something that is probably going to get worked out by people in this room and not by a drug company, which is how do you time combination therapy? What's the best time to see the best result? So in summary, regarding the new therapies, we want pathway-specific drugs, and Fovista, squalene, and the Ang2 inhibitors certainly qualify on that basis. We want drugs that are synergistic, and these 3 drugs certainly qualify on that basis. And we hope that they'll induce abnormal vessel regression, although we really don't know yet. There is a little suggestion that that may be the case for Fovista. To summarize all of the treatment of CNV, I would say that if we compare the anti-VEGF agents, from our practical point of view, the 3 agents we have today are very similar in their efficacy and durability. I'm not sure they're similar with regard to their systemic side effects. I suspect there's a subset of patients in whom there is a higher risk with bevacizumab and aflibercept, but we don't know how to identify. With regard to posology, I think that for the real-world treatment extent is probably the best way to go, but there will be exceptions, and they're trying to indicate who those patients may be. Regarding pigment epithelial detachments, I don't treat the flattening PED. In fact, historically what happens when the PED flattens is you get atrophy, so I'm not excited about pursuing that as a therapeutic objective. With regard to PCV, anti-VEGF therapy works quite well. We'll learn much more about that from Dr. Coe. It also works well for RAP. And in terms of the future, I think combination therapy is the future, and I think we're on the threshold in our way that can face a treat this disease. Thank you very much for your attention. I'd be happy to answer your questions. Maybe the best way is if you have a question, you can come up. I do, but you see, with treatment extend, it becomes a moot point. Because with treatment extend, it's irrelevant whether they have a vitrectomy or not. What's relevant is how they're doing at the follow-up visit. And if they weren't doing well, suppose, for example, I did the 3-monthly injections, and I see them back at month 4, and they still have disease activity. Maybe, if they had a vitrectomy, maybe I would think about seeing them at week 3 instead of week 4. I might reduce the frequency. So this gets into the third lecture, which is how do you approach the patient who seems to be unresponsive to therapy? But one of the options you have with an unresponsive patient is to reduce the interval between treatments. Another option you have is to increase the dose of the drug. But how you do that is based more on the response of the patient rather than whether they've had a vitrectomy or not.
And for the treatment protocol, if we extend the patient and then for a couple of times, and there's a certain fixed interval that the activity can come back. So maybe like 2-3 times when you thought that like, the activity can come back every 2 months, then you're going to extend the follow-up period in the third time?
Yeah. So remember the way it works is that when you see them back, you're absolutely giving them an injection. And that's when you begin to think, what are you thinking about? You're looking at the OCT, you're saying, is there disease activity or not? If there's no disease activity, you'll either bring them back at the same interval or you'll extend them. But if there is disease activity, you bring them back sooner. So if it was every 8 weeks, and now they come back in 8 weeks and there's disease activity, I inject them, I see them back in 6 weeks. Well, what if they had a big hemorrhage? I wouldn't see them back in 6 weeks, I inject them and bring them back in 4 weeks. And I keep them in 4 weeks until I have total control of the situation again, and then I would begin to extend the treatment. Does that answer your question?
And then after the treatment for a year or 2 years, then are you going to stop the treatment?
It depends. The way you end up stopping the treatment is when you extend the interval and you get out to 12 weeks, and after a long period of time, you just don't see any disease activity. I would probably, at that 12-week visit, break the protocol, not inject them. But instead of seeing them back in 12 weeks, I'd see them back sooner, at 8 weeks. Does that make sense?
So like it's the PRE.
Well, when you're deciding to give them a drug holiday, that means when they come back for their injection, you don't do it. But you need to be worried that they will have a recurrence. So you bring them back sooner than when you normally would have brought them back, if you had injected them. I hope that makes sense.
Like, and then are you going to extend it more, like repeat the injection every 6 months?
No, if I was doing that, I would bet the patient didn't need an injection. And there are patients, I showed you one, who just have me, so that person shouldn't be on treatment extend. They should be on PRM. But that's a very small fraction of patients. Most patients, as you'll see in the third lecture, if you look at the results of the Horizon study, you'll see most patients require injections for it. There's just a small fraction that don't. But you want to identify those people. And you can. With treatment extend, you can identify. You just can't identify them quickly. Whereas with PRM, you can identify them very quickly.
Thank you.
Yes, sir.
One question. example of what she said. Many times, I monitor this in my country, I work for Minnesota. I see many doctors extend their treatment or they overtreat. When I see many patients with retinal thinning below 200. So even when they see, they don't tolerate it. They see it very thin with a dismal intraretinal cyst or a fluid, they keep on treating. And I find out, I don't know if this is your observation, that if you continue treatment, I would tolerate it, they would decrease in vision, but instead they think that if I continue treatment, I will preserve the vision. What's your what do you stop? What do you say no?
Exactly.
Like 150, 160,
right.
And they continue treatment.
So this, in my opinion, is why we will not be replaced by computers anytime soon. Because this is a matter of exquisite clinical judgment. I can give you examples of patients who I showed you their OCT. You would swear they have 2200 vision, but they have 2040 vision. I don't make the decision simply based on the OCT. I start with the visual acuity. And it's the exception, but there are these patients that have somehow, despite very thin retinas, decent visual acuity. And what decent is, that depends on if they're monocular or not. Obviously, if they have good vision in the other eye, 2200 is useless. If their hand motion's in the other eye, then 2200 is not something to trivial. The more typical case is the person who has reasonable vision in one eye, a very atrophic retina in the other eye, with or without system fluid, let's say 2400 vision, and extreme atrophy in the OCT. I do not inject those patients at all, because
the other eye is good.
Exactly, but one of the funny virtues of this treatment paradigm is that it makes you see the patient frequently, and I'm sure you've had this experience. They're coming to see you because they're going to get the right eye injected, but in fact, what you see is there's a disease activity in the left eye. It may even be subclinical. And so you end up treating the fellow eye earlier than you would otherwise, and as a result, saving a lot of vision in that other eye. So even in a person in whom I've decided the disease is too advanced to justify the inconvenience or the expense or the risk of injecting, I will continue to see that person regularly because I know that there is at least a 50% risk that they will develop choroidal vessels in their fellow eye during the next 5 years. And it could be as high as 90%. So I agree with you that I don't just treat blindly. I guess the way I would summarize it, I'm trying to help the patient, and if I think the treatment will help the patient, I'll do it. And if I don't think it will help the patient, I'm not going to do it.
But how thin will you stop?
It isn't the thinness. What I look at is the structure. So the structure of the ellipsoid layer is more informative to me than the actual thickness of the retina. For example, I showed you the patient who has a very thick retina. The guy who has atrophy in both eyes. To me, it's remarkable that that man has 20/40 vision in the eye that I injected. So I've learned that I cannot, and I have this patient, I'm thinking about a woman who I eventually did PDT on because I couldn't, and she has a very thin retina with 20/40 vision. So what I learned from that is I'm not good at judging what the vision will be based on looking at the thickness of the retina. But I do think you get a somewhat more refined sense of what the vision will be by looking at the structure of the ellipsoid layer and the integrity of the RPE layer underneath that.
Regarding to the classic trait of glominosis, can we earlier and what is the reason behind the trait glominosis at some?
Let's go ahead.
And the second question, people talking about using 3 at X10 in the DME,
Yes.
in the another myopic CV, which has minor cases compared to this one. What did you say and what is reasonable?
Well, those are very good questions. I'm going to show you the answer to the first question today as soon as my computer does something. this slide answers your first question. If you look in all the studies, every single one of them, at the rate of visual improvement, you need at least 3 injections to get to the visual plateau. On average. 3 injections. So now you might say, okay, well, wait, if I do the first injection and they come back for the second injection and there's no fluid, why should I inject again? Here's why. Changes in vision follow changes in anatomy. So the fact that the anatomy got better doesn't tell you what the final vision will be. Just in the same way that people can have a little bit of fluid and have good vision. So anatomy is one thing, vision is another thing. They do not correspond precisely in time. So if you want to be sure you're getting the best visual outcome, you probably can't make a decision that the patients have not treatment simply based on the resolution of the subretinal fluid. Remember, we all think that the way the drug is working is by making the subretinal fluid go away. I can prove to you that that's not true. Who has the least risk of getting atrophy when you treat with anti-VEGF agents? The people that have subretinal fluid despite ongoing treatment. So we use this as a guide to treatment, but I would not confuse that with the idea that the way it is working is by making the fluid go away. But that is not proved, actually. So the fact that the fluid goes away doesn't mean that the drug has reached its maximum vision.
And what a second question. The second question is now using gene chemical in the DME.
Yes, there's a great study, the retain study actually, shows very nicely that at least with ranibizumab, you get exactly the same benefits. Exactly. Reduced injection frequency, reduced burden of treatment, comparable visual outcome. And that's why it's so important. When you look at all these different studies, like the greatest example is the Protocol 2 study. There's no one in this room, and probably no one in the world except for the Protocol 2 investigators, that use the treatment posology that was used in Protocol 2. And if I've convinced you of anything, it should be the posology affects the treatment outcome. So you cannot assume, and you should not assume, that if you use a treat and extend paradigm for treating DME, that the Protocol 2 data apply. They probably don't. Not only for that reason, but also because in Protocol 2, the patients could only be enrolled if they hadn't received anti-VEGF therapy for a year before they were enrolled in treatment. So that's why it's very difficult, I think, sometimes to take the results of a randomized clinical trial and apply them to your own clinical practice. Because many things have to line up for that to be a legitimate transfer of information.
Regarding to the corneal thickness in the PCV patient,
Yes.
is that maybe change the physician performing PDT?
Yeah, it helps me in the diagnosis, but it doesn't inform my treatment decision. And the reason it is, now I have to be careful. When I talk about treating PCV, I'm talking about treating PCV mostly in white people. And I'm not entirely sure that that's the same as the PCV patients that you're seeing. So, but for whatever it's worth, in the United States, anti-VEGF therapy really works pretty well for PCV. And I only resort to PDT when it's not working well. But that may not be, in fact, we'll run for Dr. Cohen today. In a patient population that's much more similar to the patients you're treating, what the best approach is. So I don't want to give the wrong message.
One very short question about the primary outcome of the qualification.
Primary outcome
Of the study about PCV, about the qualification.
Yes, yes.
What do you think now? Is that proper primary outcome of the qualification, or is the linear outcome, or should we classify?
For me, so again, I always try to approach this from the point of view of the patient, because it's just simple. The only thing the patient clear that the polyps, if you want them to go away, if there's a reason to do that, PDT is the right treatment. Because that really does, whereas anti-VEGF therapy doesn't. It's just that, again, talking about mostly white people with BCVA, I don't see any other benefit to the points go away.
tôi xin hỏi ông là trong trường hợp bệnh nhân nó bị AMD
Yes.
ở trong cái trường hợp bệnh nhân bị AMD mà thị lực có thể là 20 over 200 cộng với lại có scar, nó có sẹo ở vùng điểm. Như vậy thì cái mình trích anti-VEGF nó có làm cho cái sẹo phát triển lên hay không?
I don't think that anti-VEGF therapy worsens the scar. The anti-VEGF therapy could maybe make the atrophy worse, that's possible. But what I showed you, the data from the Harvard study, whether you have atrophy or not, as long as you have active leakage, there's a benefit to anti-VEGF therapy. So in your patient with 2200 vision, the question for me would be not whether they have a scar, not whether they have atrophy, but whether they have 2200 due to foveal atrophy, or whether they have 2200 due to retinal edema or subretinal fluid. If they had retinal edema or subretinal fluid, we have a treatment. If they had foveal atrophy with no fluid,